Welcome, everyone. We are excited to have you all in attendance joining us for this evening's webinar, which is MFAT, Key Quality Parameters and Current Research for Optimizing Musculoskeletal Outcomes. My name is Rebecca Flagg, Clinical Education Manager with Apex Biologix. Joining me tonight are three esteemed panelists, Dr. Nathan Katz, Dr. John Ferrell, and Dr. Ariana DeMers. They will be discussing data and clinical advantages, the quality indicators in your MFAT processing, MSK case reports and clinical outcomes post-MFAT procedure, HCTP guidance and FDA regulatory considerations, and more. All of which will be followed by a Q&A session. And to allow for the most interactive and productive experience possible, please type all of your questions in the Q&A chat that is at the bottom of your screen. So to introduce Dr. Nathan Katz, he is the co-founder, CEO, and chief scientist at Joint Tech Labs and is an industry leader in orthobiologics, regenerative, and rejuvenative therapies. He graduated medical school in Russia and received both a master and doctoral degree in the life sciences from Israel. He is a licensed clinical laboratory director by the American Board of Bioanalysis. Following his PhD in cell biology in the early 2000s, Dr. Katz quickly became part of the growing field of stem cells and regenerative medicine. Dr. Katz has authored dozens of peer-reviewed publications and presentations and is frequently invited as a keynote speaker and expert at scientific and clinical conferences. Next, Dr. John L. Ferrell III is a board-certified family medicine physician with fellowship training in sports medicine and musculoskeletal sonography. During his fellowship, Dr. Ferrell worked with the Washington Nationals and Redskins and served as a team physician for George Mason University while receiving intensive training in ultrasound diagnostics of musculoskeletal injuries and regenerative medicine injections. He believes in a holistic approach to the musculoskeletal system, and the bodies need to be treated as one entity. Dr. Ferrell's primary focus is on non-surgical management of orthopedic conditions using regenerative medicine to include microfragmented adipose tissue, bone marrow aspirate concentrate, platelet-rich plasma, prolotherapy, and 10X. He is also a sought-after speaker, trains physicians nationally and internationally on regenerative medicine and ultrasound guidance, and is involved in continued research in the field. And last but certainly not least, Dr. Ariana DeMers is a board-certified and fellowship-trained orthopedic sports medicine surgeon. She previously served as president and board member of the Interventional Orthobiologics Foundation and is recognized as a prominent educator and trainer in orthobiologics and ultrasound. Dr. DeMers has successfully transitioned her rural practice away from commercial insurance, emphasizing a holistic approach to orthopedics. Additionally, Dr. DeMers is committed to driving systemic change within healthcare to enhance the experiences of both patients and physicians. She established Women Physicians in Orthobiologics and Wellness, a community that fosters mutual support in business, medicine, and personal development. Currently, she serves as vice chair of the Academy of International Regenerative Medicine and Surgery Society and co-chair of the 2025 Biologic Association Summit. So without further ado, we would like to kick off this presentation and pass the time to Dr. Katz.
All right, let me share screen. Okay. Good evening, good morning, everyone, wherever you are. Nathan Katz, I'm CEO of Joint Tech Labs. I'm going to talk about orthobiologics, the group of products made of own patient tissues for injectable. And we as a company focus, first of all, on adipose. And that's what majority of my talk will be, but we'll touch base about PRP and bone marrow and comparative biological properties of those orthobiologics as well. Fast. Okay, so microfat, it's one of the option of choice as orthobiologics. What is microfat? It's pretty much fragmented fat that preserved the stromal cells in natural niche. And this fat is made by micronization of adipose tissue. Usually, microfat is a size of particles between 300 and 800 micron. And as I said, used as injectable in any type of settings. So microfat consists of the two major components. It's jumping too fast. Okay, so there's general misconception about fat. Fat is not just the thermoregulator and the wrap of our bones, but it's very complex organ that perform multiple function in our body. Endocrine, paracrine is it's the sex steroid depot, and of course is depot of the stromal cells that actually pose the major active factor of adipose microfat product. So two major components, as I mentioned, it's a vascular with the cells preserved in the natural niche, which part of those cells, of course, mesenchymal stem cells, and it's a major source of our body of mesenchymal stem cells, and extravascular content, which is adipocytes and extracellular matrix. So what we use microfat? Microfat, again, it's purified form without disrupting the histological integrity of the adipose tissue. It preserves, and it's very rich in preserved regenerative cells, rich in regenerative cells, and can be injected. Of course, it should be produced in a particular way to minimize the damage to the tissue and particular regenerative cells. Now, the parameters of the microfat defined by multiple factors, but it's important to understand that the qualities of microfat made in different ways, they're different. So what is important? We know that the free oil is toxic. It's been published. It's known that it's can affect the tissue, particularly cartilage. So presence of RBC contamination considered as the very negative factor, because we know that even single joint hemorrhage may result in apoptosis of the chondrocytes and eventually lead to destruction of the joints. So cell debris. During the manipulation of the tissue, we can produce massive amount of this cell debris, because we actually we can damage the adipocytes and cause the leak of the oil. And of course, the cell debris is the known source of the free radicals and that cause the oxidative stress. So the particle size is also a critical parameter, because when it's too high, too large, it's actually can be reason for the apoptosis, because the large particle doesn't allow for the nutrition actually support the viability of the stromal cells. Now, also if the particle size too small, so it means we chopped the top of the tissue too far, and then during this process we can produce a lot of free oil that we just said that it's a negative factor. Now, liquefying the fat too far down to the particle size below 300 also make effect on the viscosity, and in some application it's important to preserve viscosity, so to keep the adipose tissue in particular location, not microfat, where we deliver it. Now, the ratio between the lipoaspirate and the final product, it's very important, because it defines how much fat we need to harvest and how much fat will be available for injection. So as less damage we have in the process, as more volume we actually have for injection, and that's important to understand. Now, the most critical, probably the most and less spoken factor is the dose. So if we read through the dozens and hundreds of publications, very few talking about how much cells, actually stromal cells, are injected in particular clinical trial or report. And we made the study where we compared several methods of making MicroFAT, and Tonart is known as the very first published method of producing MicroFAT, or NanoFAT at that time it was called, which is simple manipulation of and liquefaction of the fat between two syringes, two lipograph, which we call filtration devices based on the filtration through the mesh, MiniTC, our product, and lipogems, which is comparable by the concept when the fat is washed intensively before gently fragmented. So we compared, and you can see on this bottom line how many cells actually can be injected when we using for injection about 10 milliliter of the final product. The difference is pretty significant, I would say. So here, so beside the number of the dose of the cells that we're injecting, what is important to understand actually how many stem cells do we have in the final product, in the product that we're injecting, and that can be determined by counting CFUF, colony forming unit. So we compared one of the method that's very common in for plastic surgeon, but we found that it's been adopted by orthopedic doctors and physiatrists, so which is called body jet. It's very convenient and very fast, where the harvesting is happening at the same time with infiltration. And it's seemingly the number of cells you can see here, it's 1700 versus 1400, pretty much comparable, even higher than in MiniTC. However, when we're counting CFUF, we can see it's a 10 times different. 10 times, 750 versus over 6,000 CFUF. In percentage, it's exactly 10,000, it's 10 times more. So the, not 10 times, it's 100 times actually more. So it means what it means, and that's important to understand, that counting the TNC, it's not absolute number, because TNC, it's not just the stem cells, it's the actually stromal cells could be contain pretty much the blood cells, lymphocytes, white blood cells. And in this case, this machine actually producing very badly contaminated by blood product, where the stem cells present in very low number. So that's what we know. Now, we also try to manipulate and produce NanoFAT, which is below 300 micron. There is particular trade-off here, we understand. We can produce NanoFAT, and it reduces about in half number of CFUF, yet it's still comparably and significantly higher than what we can get by just simple harvesting of the fat. Now, design of the device, of course, is important. As I said, that's why we're getting those numbers that I was just telling. And so our device actually, the concept makes the fat washed, first of all, by simple 50 ml, small amount, 50 ml of lactated ringer, and then all the debris and everything gets washed out through the bottom membrane, which is 100 micron. Fat cannot go down there. So from the bottom, all the impurities can be collected and discarded, whereas the fat actually going through this membrane and accumulated in the middle. Now, it's very important that every step in the process is critical, from aspiration through the process and injection. So we designed particular syringes and cannulas that produce precise number of the particle, precise size of the particle, and reduce the shear force that can damage the fat during the harvesting. So it's all start from the cannula through the syringe design, extensive washing, gentle fragmentation, standardized force and time by the processing, which is defined by the centrifuge, and entirely in closed loop manner. Now, do I have still time, Rebecca? Yeah, okay. So we studied actually what happening in terms of biological effect between cells and the cartilage. You can see on the slide that this is the study was based on the cadaver cartilage explants, and we added adipose stromal cells. The study is in vitro study. So this picture is the cadaver cartilage. It's viable. You see the green dots is the chondrocytes actually, and on top of it you see all these cells. This is the expansion of the cells on the surface of the cartilage. So it means the cells cannot touch. It's adherent cells. This is exactly what mesenchymal stem cells do in vitro in the plastic dish. And the most interesting here, the most interesting results of this study was here. So PG synthesis of the cartilage. So you can see on this graph that actually during the exposure of the adipose stromal cells with the cartilage, on day 24, we have two formats, by the way, of the cells, just the bare cells and the cells encapsulated in particular gel. We actually try to see if we, let's say, use the PRP gelation and encapsulate the cells will behave differently. So in both groups, on day 24, there is significant increase of the PG synthesis in the cartilage. So the cells are actually, and the fat, it's not just lubrication, it's not just padding, it's very active product that enable interaction of the cells with the cartilage. And by producing and stimulating PG synthesis in the cartilage, we can claim that this treatment actually makes the cartilage stronger, can preserve the cartilage, and stop deterioration of the cartilage during osteoarthritis. Now, the another factor here was the ratio of the IL-1 receptor antagonist versus IL-1, which is inflammation, and antagonist of this IL-1 cytokine, which is the known major lead factor for the inflammation. Also here we saw the increase of this ratio versus control on day 14 and on day 24 in both formats, encapsulated and non-encapsulated. So we have structural effect on the cartilage by triggering PG synthesis, and we have anti-inflammatory effect of those cells. And which is interesting to mention, and I won't go through all these graphs, I just say that multiple these cells, adipose-derived stem cells, and mesenchymal stem cells, adipose stem cells, I call them, or signaling cells, as late Arne Kaplan called these cells. So these cells very smart, they're adapting themselves to environment. So in this inflammatory environment, they're producing the factor that known for immunomodulation of the cartilage. And this factor, you see all this factor on day 14 and day 24, they actually statistically significant higher than in control and in the beginning. Okay, and they, as I said, adaptive because factors that are not good for cartilage at the osteoarthritis, like VEGF. VEGF is a very known factor produced by platelets, produced by adipose stromal cells, but it's good for the application, let's say, in ischemic condition, in wounds. Here, cells somehow recognize that VEGF is not good for the cartilage, and they dumping it down during the time of interacting with the cartilage. Now, I would like to mention a couple words about all this group. So major three orthobiologics, PRP, adipose, bone marrow. So we just talked about adipose, how it works. These cells, as I said, working for weeks, days and weeks. We follow those cells and interaction with the cartilage for 24 days, cells were viable, they attached to the surface of the cartilage, kept producing cytokines and the growth factors. Now, with the PRP, the story a little bit different. So we know that platelets were producing massive amount of the growth factor cytokines. However, the half-time of those factors is really short. That's why we, in most of the setups, in the clinical protocols, PRP applied in series. Now, bone marrow, it's comparable to PRP by the comparable, but it's much more powerful because it contains way higher amount of the growth factor and cytokine than PRP. So because of this high amount of the growth factors PRP that can be injected at once, so bone marrow usually applied at once and managed to set up the healing effect. Now, in general, all these three orthobiologics initially producing pro-inflammatory factor that changing into anti-inflammatory with the time, they trigger recruitment of the immune cells of the body itself. So adipose has several layers on top of it, which is anti-inflammatory effect, as we said, that can last for long times, the signaling effect of the cells, again, that lasting for long time with interaction with the cartilage, of course, mechanical padding, and as I said, regenerative effect for the cartilage, which definitely missing here. However, as I said, not every condition, of course, needs all this layer. And multiple applications, several applications, particularly high dose of PRP definitely produced and known and published as very effective treatment for different musculoskeletal application, as well as bone marrow historically known as productive and effective orthobiologics. So about the PRP, we know multiple publication, most of the publication, vast majority of the publication is actually in favor in supporting the PRP efficacy. It's interesting to see in their publication, of course, we know that saying that PRP is not effective. So, and we look on all the studies, it's 34 randomized control studies, 100, this published a review of 134 studies and Banzal studies that showing the dose is very critical for PRP. In all the studies we looked, the dose was ranged between 5 and 10 billions. The studies published here, they didn't mention in the study actually the dose and number of the platelets. However, we calculated it through the description of the method, and we saw that the dose in the study that not supporting PRP below 4 and below 3 billion. So the difference between those, that would define actually the efficacy of your product, and that's what is important when you choose your method of preparation of your PRP product. So what I was saying, in PRP, number is actually not the ultimate number. In fact, it's important to understand, and I think it's very few and very rarely mentioned that there are factors that affecting the functionality of the platelets, and those factors. So that's not just the number. Same number of platelets may contain different concentration of the growth factors. So I found this review by Kaffler, which was astonishing for me to learn stuff that I didn't know before, like the physiological status of patient actually can affect the concentration of the growth factor in the platelets, like the stress, caffeine, alcohol, smoking can increase the serotonin level in the platelets. Serotonin, we know, is it's a mitigator of the pain. So high level of the serotonin in the platelets would create the flare, pain, and more pro-inflammatory until we get there and when it's switched to the pro-inflammatory status. So activation method of the PRP important, and effect and actually can trigger in different direction how many of particular type of growth factors we can have in the final product. So, and of course, the type of tissue where PRP is applied also has affecting actually how the PRP gets activated if it wasn't activated before. With
Dr. Katz, I appreciate your insight on this. Is there anything that you would like to close up with? And we do need to
yes, absolutely.
Dr. Ferrell.
So
Thank
it's
you.
pretty much the last one, which was about the bone marrow. The bone marrow, so I will just close up. Bone marrow was considered for a long time as stem cell therapy. However, it's a pretty known fact that bone marrow contains less than 0.001% of MSCs and also very low CFUF number versus if you compare to adipose tissue. However, it's a huge source of the different cells. 50% of the bone marrow content is named macrophages. So the effect of bone marrow, it's important to understand, it's not stem cell therapy, it's immune modulation, and it's effective. It's effective when the dose is right. So Centena is talking about the threshold of the 400 million. However, I just recently faced the dose, which is about 2 billion and above, that feasibly can be, depends on the technique of the bone marrow harvesting. So all this factor needs to be counted and calculated. So I will sum up, and thank you so much for your attention. Any question in chat or at the end of this webinar?
Thank you so much, Dr. Katz. Yes, as he just mentioned, if you have any questions, please put them in the chat or the Q&A function below. And we will now pass this along to Dr. Ferrell.
Thank you. I'm going to share my screen. So she said, my name is Dr. John Ferrell. I'm out of Washington, D.C. with regenerative orthopedics and sports medicine. And today we're going to talk a little bit about fat. Nathan did an amazing job talking about the basic science, and I want to kind of talk a little bit more about just kind of clinical use and applications and present you with a couple of case studies. We'll talk a little bit about some of the data that's out there. And we want to be able to use that literature to really identify who are good candidates to use fat on. We want to also look at kind of, some standard cases and some more interesting cases. And then I want to convince you that, to use fat on your patients, and also convince you that fat's really awesome. So first, we're going to talk about fat in shoulder use. So when we're talking about shoulders, this is a study that actually is a basic science study, and it used human tendon cells from rotator cuff, and they added MFAT to it. And what they found is when they added the MFAT to these rotator cuff stem cells, that the MFAT significantly increased the stem cell proliferation. It also enhanced the VEGF expression. And they kind of concluded that when you add MFAT to these cells, that it increases a paracrine action, enhancing stem cell proliferation while maintaining the stem cell's activity. It also enhances the VEGF expression, which is crucial for neovascularization and the healing process. So it creates new blood vessels to allow healing and stimulate that to kind of get things better. Next, we're going to talk about a case study, and it was looking at 18 shoulders. This is done by Dr. Joanne Borgstein, and she's had 60 patients with 18 shoulders, and she did one MFAT for people that had rotator cuff pathology and shoulder joint osteoarthritis. And what she found is that there was significant improvement in pain and function scores starting at 6 months all the way out to 12 months. So this is one of the first kind of case studies out there looking at using this for rotator cuff as well as for shoulder arthritis. Next is a study by Dr. Kevin Dar, and he had 25 patients that had shoulder arthritis, and the groups were mild and moderate, and he kind of followed the standard outcome measures after he treated them with MFAT. What he found is that both groups had significant improvement in their VAS scores as well as their DASH scores that last all the way out for 12 months. What I thought was even more impressive is when he followed X-ray pre and post, he actually saw increased space in the glenohumeral joint at that 1-year follow-up after treating them with MFAT. This next study is now looking at using MFAT in combination with arthroscopic repair of a rotator cuff. And so they had two groups. One was the arthroscopic repair, and the other one was MFAT plus arthroscopic repair. And what they found is that 3 months and 6 months, the group that got the MFAT had better outcomes and the earlier recovery at 3 months and 6 months. They also showed statistically significant improvement in pain, function, and activities of daily living at 3 and 6 months. They also found that they had increased isometric strength with external rotation in the group that got the MFAT at 6 months. There was no major difference in the long-term healing when they repeated the MRI at 18 months, and there was no adverse reactions to using the MFAT. So I want to switch gears a little bit and kind of talk about one of my cases. So this first case is SB. She was a 70-year-old female. She's had shoulder pain on and off for multiple years, but it really got worse for about 5 months right before she saw me. She saw multiple other providers, and they treated her with some conservative care, such as physical therapy, NSAIDs, and cortisone injections. So by the time she got to see me, we did a physical exam. On her exam, her range of motion had flexion up to 135, abduction to 110, external rotation to 35, and internal rotation to 70. She had 8 out of 10 pain with activity using the shoulder. Her strength was pretty weak with abduction at 3 out of 5. Extension was 5 out of 5. Her external rotation was 4 out of 5, and forward flexion was 4 out of 5. She had a positive empty can and a positive O'Brien's test. She had an upper extremity functional score that showed her disability score at a 72 and her severity score ranging from 60 to 79. And these were the problems she had with her ADLs: pain with washing her hair. She was unable to take her shirt off without help. She was avoiding any type of lifting because it gave her pain. She was unable to reach above her head. And during the night, she was waking up multiple times while sleeping. So we got an MRI to kind of see exactly what was going on in there. And here's what the MRI looked like. And we actually have the reading from the radiologist, which read it as a full thickness tear of the anterior leading edge of the supraspinatus tendon. And it was measuring 1 centimeter by 0.8 centimeters. There was also a low-grade partial thickness articular sided tear at the posterior supraspinatus / anterior infraspinatus at the footprint. So we had the talk. We said, hey, I think you need to be evaluated by a surgeon. This is a full thickness tear. These are typically repaired by surgery. Obviously, if you were looking for a non-surgical option, we can talk to you about some options that can probably help out with pain and function. There's some good data to show that using MFAT around shoulder osteoarthritis seems to decrease the pain, and that might give you more pain, but it may not return all of your function. So she said, I absolutely do not want to do surgery. Give me your best option. And so we decided to progress with MFAT. So we treated her in October. We did 3 mLs to the MFAT to the shoulder joint. Using ultrasound guidance, I was able to identify the supraspinatus tear, and I said, we're going to put the MFAT right along the supraspinatus tear to see what would happen. We also put it 3 into the infraspinatus tear, 3 into the biceps tendon, 3 into the superior labrum, and then 3 into the posterior labrum, all under ultrasound guidance. When she followed up 6 months after the procedure, grossly, her strength was 5 out of 5 bilaterally. She had a negative empty can test, a negative O'Brien's test. Forward flexion was 175, abduction was 150, external rotation was 80 degrees, and internal rotation was 60. So she had significant improvement in her pain and function. Her upper extremity functional score at this time, disability score is all the way down from a 72 now to 15. Her severity score was 1 to 19, and she could wash her hair, take her shirt off, lift 10 to 15 pounds without issues, no difficulty with reaching, and no difficulty with sleeping. So obviously, we're following this over time, looking at the ultrasound, and the ultrasound was showing evidence of this rotator cuff actually healing. So we said, hey, let's send you back and let's get another MRI. She actually, was able to return to the gym. She was able to perform her upper body exercises pain-free, had significant improvement in her quality of life, and able to play catch with her grandchild. So we repeated her MRI at 9 months out after the treatment. It's read by the same radiologist. And he said, status post rotator cuff repair, scarring and attenuation of the supraspinatus tendon at his footprint related to a chronic tear and post-surgical change. No recurrent full thickness tear was identified. So this, we were kind of, flabbergasted. We see the healing that came in through this area. Functionally, she was doing better, and we had an MRI to kind of back that up. And, what I wanted to also do is just kind of share with you how she felt in her own words.
And Sarah, you were able to avoid surgery by seeing Dr. Ferrell. Tell us a little bit about your journey and how you found Dr. Ferrell.
I had had a partial rotator cuff tear for 20 years.
And that was back in 2019 that this all
Yes.
took place. And here we are in 2024. And how do you feel?
Oh, I'm great. I can bench press 40 pounds in the gym. I can do overhead press with 20 pounds. I'm fully functional.
So obviously, this is not standard of care, and I'm not suggesting that everybody with a full thickness tear come and get MFAT, but it's kind of an interesting option that we can look at this for people that have poor surgical candidates that don't have significant retraction. Hers was less than 2 centimeters. She had no fatty atrophy of her rotator cuff. And so this was an option that, we can do in that early stage, and those people that don't have many great other options. So we wrote this up, and it's in the Regenerative Medicine. This was published last year, and you can find all the details of this case study that was kind of published last year. Next, we're going to switch gears a little bit, and we're going to talk about knee osteoarthritis. This is where I truly love fat and using fat for knee OA. The first study we're going to talk about is with Dr. Gobi. Dr. Gobi did a 2-year international study. He had 120 knees and 75 patients. The average age was 70. So these people were not spring chickens. They had KL 2 through 4. 4 is bone on bone. He treated these patients, had 106 out of the 120 knees were considered a success. That's an 88% success rate. He concluded that one single dose of MFAT could improve pain, function, and quality of life enough to avoid knee replacement in people that had KL2 and 2 through 4 grade osteoarthritis. Next study, this is a study that came out of Europe, where they have universal health care, and they're trying to do whatever they can to decrease costs to the system. So this was 220 patients, KLs 3 and 4, one single MFAT injection, and they followed them out for 2 years. And so what they found is that they had statistically significant improvement in quality of life in the groups that had an OKS score of 39 or less. But even in the groups that had OKS scores of 27 or less, these are people that are bone on bone, these are classically surgical patients, had significant improvement in their pain and function that they could avoid surgery. And that was all the way out for 2 years. Next was a meta-analysis looking at MFAT use and review of studies ranging from level 1 evidence to level 4 clinical evidence. And so, long and short, the meta-analysis showed that MFAT causes significant improvement in pain with VAS scores. All of the KOOS subscores, they found an increase in improvement in. They found improvement in WOMAC scores. And so they cautiously said, hey, MFAT injection works to improve pain and function. These are moderate study quality, moderate risk of bias, moderate evidence, certainly. But overall, this is something that they can see. More studies need to be done, but it's obviously helping patients out. Next is one that's looking at MFAT in combination with arthroscopic debridement. 78 patients, half got debridement alone, the other half got debridement with MFAT. They looked at assessments all the way out to 6 months, looking at some of the standard quality measures. So they found significant improvement in the group that received the MFAT over the group of just had the arthroscopic debridement in both KOOS scores, KSS scores, and also functional scores. But what was really interesting is they actually saw changes on MRI. The T2 mapping scores actually improved in this group that had MFAT treated to the knees. So they concluded that MFAT combined with arthroscopic debridement can improve your functional outcomes, your MRI appearance, and they support its use in using it for knee OA. We're running a little short on time, so I'm going to run through this one a little bit fast. So this was my next case. So this is a patient of mine. She's been a longstanding patient, and this is kind of our more standard treatment for kind of MFAT. And so she came in to see me after seeing 4 or 5 other providers that pretty much said, your options are straw treatment or surgery. She said, what was the straw treatment? Suck it up, right? So those are really her two kind of options that they kind of gave her. And she said, I did not want surgery for my knees. I didn't want surgery for my hips. And so she came and we talked about kind of different treatment options for her. And we decided on doing kind of an MFAT treatment. So we did the MFAT treatment, and she came in and she said, "Hey, doc, telling you, I'm an athlete." They all say this, right? I was super active, and at this point in time, she was a little bit overweight, as you can see her before the treatment. And I said, okay, sure. So we treated her. She does great, and so her pain improves within 3 months. She had about a 60% improvement in pain. By 4 to 6 months, she was about 90% there. She started getting active in the gym. She lost 50 pounds. She's back doing all the things that she wants to do, and she couldn't be happier. And so, these are just, some of the stories that we see over and over again where people come back and they say, "Doc, you've literally changed my life by giving me a non-surgical option." And FAT's been amazing to do that. So a lot of times when we talk about, our so-called stem cell treatments for arthritis, we always compare fat to bone marrow. And so the question is one better than the other? So Ken Motner did a study with 76 patients, 106 knees, and he had bone marrow in one group, MFAT in the other group. And guess what? He found that both groups did extremely well. The decreased pain, increased range of motion, had people feeling better. But there was no statistical significant difference between the two groups. So this is the conversation that I have with my patients. Bone marrow works, MFAT works. When I give them that option, most of them say, "Take my fat, I have plenty." So I'll save the questions for the end, and I will pass this on to Dr. DeMers.
All right. Thank you so much. I'm going to go ahead and I've been tasked with a amazingly fascinating subject of regulatory. So we're going to talk a little bit about regulatory. I always get a lot of questions about yes, but what about the FDA? Yes, but what about regulatory? So I'm just going to give this a quick little primer. We're going to talk about who's in charge, what's under FDA regulation, and so who's in charge? The FDA. Is the FDA in charge of PRP? Turns out it's not. But what is this HCTP? Well, it's human cells, tissues, and cellular and tissue-based products. And this is who regulates these things. And they regulate orthobiologics. And under different pathways, it depends on intended use and complexity. So in the 351 regulation pathway, it is requiring pre-market approval, a biologics license. In 361, this is where we live in our orthobiologics, such as MFAT or PRP or BMAC. And this can be marketed without pre-approval if they meet certain criteria like minimal manipulation and homologous use. We'll get a little bit more to that later. So things to consider, we really are living in this 361 version. 361s are gene therapies and stem cell therapies, and they're put out by companies and they're considered drugs. So when you're using human cells or tissue, you need to use an approved product or procedure that's a 361 pathway. So these guidance documents are really interesting, and the FDA has put out very, very clear documents on what to do. So in November of 2017, they put out a document that talks about the HCTP needs to be minimally manipulated and intended for homologous use. And it does not involve the combination of cells or tissues with other articles, except for water, crystalloids, or sterilizing or preserving or a storage agent. And so they also said that the HCTP cannot have a systemic effect and is not dependent on the metabolic activity of living cells for its primary function. So you should be able to be qualified for a 361 pathway to get approval. You have to hit all of these highlights. In 2020, there was an update on the minimal manipulation part specifically. In part 1271, they defined minimal manipulation for structural tissue, the processing should not alter the original relevant characteristics of the tissue relating to the tissue's utility for reconstruction, repair, or replacement. For cells or non-structural tissues, it should not alter the relevant biologic characteristics. So the other part of this that you need to understand is that the HCTP is intended for homologous use as reflected by the labeling by the manufacturer or advertising or other indications for the objective intent. So really, we have to be clear on what we're talking about. Are we talking about the physician use, or are we talking about a manufacturing guidance document? And then to get a little bit more clear, we have to clarify, are we structural, are we not structural? A tissue is considered structural when it physically serves as a support or a barrier or conduit to cover or cushion tissues. That's structural. Non-structural is more of the metabolic or biochemical rules, such as hematopoietic or immune functions, and that's for the purpose of applying the HCTP regulatory framework to decide whether you need to have a 351 drug pathway or a 361 tissue pathway. So when we look at a minimal manipulation, that section 1271 provides two definitions of minimal manipulation that applies. One is structural tissue, one is non-structural. To be clear, microfragmented adipose tissue is considered a structural tissue. And so minimal manipulation means that the processing of this tissue does not alter the original relevant characteristics of the tissue relating to the tissue's utility historically for reconstruction, repair, or replacement. So just an FYI, platelet-rich plasma is not even considered an HCTP. Neither is bone marrow, to be really honest with you, unless you're doing something to be more than minimally manipulating this tissue intended by the manufacturer for non-homologous use. So when we're talking about adipose, this does fall under the HCTP, but this is a structural tissue. These are some examples of structural tissues. Non-structural tissues are more cellular. It's peripheral nerves, pancreatic tissue, something that's secreting something. So they even go so far as to talk about examples from the guidance documents. And I will just clarify this, the basic function per the FDA is that the adipose tissue includes providing cushioning and support for other tissues. That's their thought on what the basic functions of adipose are. So when they give examples from the guidance documents for talking about it and marketing it and labeling it, the adipose tissue is used when we're talking about using it for cosmetic reasons. This is homologous use because it's used to provide cushioning and support, which is a basic function of adipose. If you are talking about using adipose tissue to treat arthritis by regenerating or promoting the regeneration of articular cartilage or tendon, this is not generally considered homologous use because that's not the basic function of adipose. We have to be clear that this is what we're promoting, what we're talking about out loud. So again, if you're saying that you're using adipose tissue to treat neurologic disorders because what the function of the tissue does is limits autoimmune reaction and myelinization, this is not considered homologous use because fat is not, it is considered to provide structure and cushioning and support. It may also do those things, but per the FDA, their thoughts on adipose is it's just using cushioning and support. And that's how we're asked to speak about this. So just to clarify, this is basically guidance documents for manufacturers that we are using to also be safe and reasonable in the field. So what about a 510K cleared device? 510K clearance means that the FDA has determined that the device is to be substantially equivalent to legally marketed devices, and they don't need a pre-market approval, and that you can use a 510K cleared device in your clinic when providing orthobiologic treatments, as long as the device is intended for the specific use you have in mind, and it's appropriate for your patient's needs. We're going to go a little bit further and say, what about off-label use? So off-label use refers to using a medical device or a medication, which we do all the time, in a way that it was not specifically labeled and approved by the FDA per the device's labeling or the drug's prescribing information. We do this all the time. This often occurs when a physician believes that using the approved device for or medication for a different indication or a different patient population may benefit the patient. When can they use it? Using medical judgment that you believe it's the best course of action, when there's a lack of approved alternatives, and in emergency situations. You have responsibilities. If you're going to use it off-label, you need to provide informed consent, documentation, monitoring, and please stay current on the latest clinical evidence and guidelines related to this off-label use. So how do you educate your patients? You give them an explanation as to why you think an off-label use may be appropriate, and we discuss the risks and benefits, we discuss the alternative options, and we provide them an informed consent. So who else, and this becomes important, who else has regulatory purview? The FTC. And what they care about is your website, your written materials, and your advertisements. This is very important. So please, to stay safe from the FTCs, you avoid misleading claims, such as, oh, MFAT is used to remyelinate nerves. Please just avoid those misleading claims. That might be true, but we don't want to be misleading. We don't want to be talking about this as a thing that it has not been approved by the FDA. We want to clearly state the limitations, use evidence-based information, disclose those potential risks when you're talking about your treatments, and then really make sure how to contact the clinic, disclaimers in terms of use, this may not be true of everybody that we treat, those kinds of things, just to really make sure that you cross all the T's and dot all the I's. When you want to put something out there on the web, put something in print, just maintain compliance with the FTC guidelines, providing accurate and responsible information, staying updated on the regulatory changes, and then, if necessary, consult with those legal professionals. So how do you stay out of trouble? Autologous products, approved devices, clear communication. So with that in mind, where there's great power, especially with orthobiologics, we do have a great responsibility. So thank you so much. Hopefully this was a little more clear. Lots of mumbo jumbo. We're just going to stop sharing my screen, and then we will turn it over to the Q&A. And we do have one Q&A. Hopefully we don't have... oh, there may be some in the chat as well.
There's another one too, Dr. DeMers, I kind of wanted to start with.
Yes.
That's definitely a hot topic that we got in, that what is an appropriate amount to charge patients for an MFAT procedure and injection, and how do you have that conversation with your patients?
Yeah, so, I loved Dr. Ferrell's approach. It's like, hey, these work the same. What do you want me to do? You want me to take your bone marrow, or you want me to take your fat? And I would agree with his experience that 75% of my patients, when given that choice, choose MFAT over bone marrow concentrate. They're like, shoot, I have a lot of that. Can you just take it all? So they're very happy to get rid of their fat, and they're actually shocked that now this thing that's been driving them crazy, this extra little roll, is now going to be put to great use, and it can actually be used to get them off the couch, get their knees feeling better, and get them moving again. So that's like a double win for our patients. And then the question is how do we talk to our patients? And I'm guessing, how do we talk to our patients about cash pay, right? And so one of the things we have to provide value, and what John and Nathan have done is provided you guys with so much value that you can share with your patients. These are expected outcomes that we know we can get 2 years down the road and avoid a knee replacement. We know that it is possible. As much shock as both John and I had with this healed rotator cuff, it is possible. It is one of those things that, holy cow, this is almost feels like magic, but we have scientific evidence that this is an opportunity to avoid those things. Instead of saying, just suck it up and live with it, we now have alternatives that we can provide our patients for improved function and decreased pain. And so that's what we talk to them about. And when they say, gosh, I'd pay anything to get out of this pain, that becomes true, and we don't want to take advantage of our patients. And so we do want to appropriately price these things, and we don't want to undervalue and underprice, because we also have costs for our clinic. And so I think that the range that we see, and John, you can back me up on this, but I think the range for the MFAT that we're seeing is somewhere between the $2,500 range to the $4,000 range for those treatments. And usually it is a one-time treatment, and it does not have to be repeated, as Nathan said.
Yeah, so I think that, you're a little bit more in rural California. I'm in a big city. And so in some of the bigger cities, I've seen the kind of ranges go from $5,000 to 10,000. And, I think that,
All right, I should move to the big city then, man.
And I think that things that you take into consideration is the amount of time that it takes to do the procedure. For a lot of people, this is about a 2-hour procedure. So it takes time and effort to kind of do that. Obviously, you want to do the injections under a musculoskeletal ultrasound that allows you to be extremely accurate when injecting that into those areas. And then, the other conversations that we kind of have is, usually these are patients that their only other option is surgery. And, with many high deductible plans, when you're looking at, a $40,000 knee replacement, and you're going to be paying, 5% of that, or 10% of that, these numbers start to kind of, add up and even out. And so, this is obviously not for every single person, but it's a conversation that you have. And, I don't know anyone's finances. And for some people, they say, you know what, if I can avoid surgery and I have an 80% chance of being functional and it will last me for 3 to 5 years, this is worth it to me. For some people, they're going to say, absolutely not, doc. I can't afford to do that. And that's perfectly fine. But what we're doing is we're giving them an option for people out there that want to try to avoid surgery, and have good evidence to back it up.
Yeah, absolutely. I think there's the conversations that I have with clinicians, I think we forget that people are really struggling with insurance coverage, and insurance doesn't cover as much as you think it is. And a lot of people have these high deductible plans, and they are given, they are responsible for the first $5,000, $7,500, $10,000 before anything is covered. And so even if you can come under that amount, you've saved them money. And then if you also have decreased the risk because you're not getting a general anesthetic, it's less invasive because you're not having a big incision, you have to share those options as well. So there was a question, where can we get the 510K? 510K cleared device, this Joint Tech Labs MiniTC is 510K cleared. If you're asking the device provider, you can just ask them for their 510K clearance. Nathan, do you have anything on that? Oops, you're muted.
Yeah, the 510K clearance is pretty broad. It's pretty much for any type of surgical intervention. So what we do in I mean, it's supposed to be in surgical settings. Whatever we do, it's in non-surgical settings. It's actually considered off-label use. So that's what we know.
Awesome. Thank you so much. So there's a question about, has there been a comparison between the therapeutic effects of nanofat and microfat? For MSK, I don't know that that's been done. I know for plastics, Nathan, maybe you can share a little bit more on your knowledge base, nanofat versus microfat.
Well, it depends on application, of course. So as I said, nanofat, you have a trade-off in terms of the cellular content, yet it still contains pretty high amount of the stromal cells. So it depends on the way it's made. If you can produce nanofat in a particular way and get rid of all debris and the excessive oil, then your product pretty good to go. And in aesthetic application, it definitely works pretty good. What we know from, unfortunately, most of the devices that I know on the market, they pretty harsh on adipose. And unfortunately, those publications on nanofat were not convinced. And I think that's the reason that it's still kind of the doubtful, I would say, outcome of nanofat in some publication, particularly comparative studies, because the quality of your product is really inferior, to be honest, to what it's supposed to be to achieve the result. So nanofat, yes, if it's made in the right way.
Great. Okay. So we have a question about if patients have already had surgery with extensive scar tissue, can these MFAT therapies have a therapeutic effect?
So, I think a lot of this
John?
really depends on, what specifically are they talking about. So the MFAT, has a great effect on scar tissue. And this is one thing that, dermatologists and plastic surgeons use it for, is to treat scarring after C-section scarring, things of that nature. And if they're talking about, hey, you have somebody with bad knee osteoarthritis after a, knee scope and some arthrofibrosis, I would say, yes, you can look at having some decrease in inflammation, right? We can find that the MFAT changes M1 to M2 macrophages, which creates an anti-inflammatory effect. And so you may not get the increased range of motion, but it will definitely help out with some of the pain kind of associated with it.
Yeah. There's a question, John. How many of these procedures are each of the panelists performing each month?
I'm doing about 2 a week.
Yeah. Yeah, I probably do 1 to 2 a week as well. And you have to calculate and account for the time. That there is a time factor. It's not a 15-minute injection. There is time for harvest, time for processing, time for very precise ultrasound guided reinjection. But the time investment for the patient is phenomenal. And this is for a lot of things that we do, we expect it to be a single injection. I call it a one and done.
There was also one talking about, compared to PRP, will MFAT last longer, even if it was high dose was given. So I can speak anecdotally. My PRP patients with arthritis typically get 1 to 3 years of relief. My MFAT patients typically get 3 to 5 years of relief. We have data on MFAT up to 4 years showing benefit. I have not seen data, even high dose data on PRP lasting that long, but I could be wrong. I don't know if you can think of anything lasting that long for PRP.
I think it's application dependent. For arthritis, I think your data is, 1 to 3 years is appropriate. I think I usually quote 12 to 18 months for PRP. I do know that we have pretty good data that it is longer than that for MFAT, up to 4-year data. What I've seen. Okay, so there was a question about volume of fat and tumescence aspirate needed to produce about 15 mLs of microfat. So I'm definitely an over harvester. I over tumesce, over harvest. People are really happy to get rid of the fat, and I never want to be cut short. So I do a lot of tumescence. I do about 250 per site. So if you're going to, it's usually a 2-to-1, 3-to-1 ratio forever. If you're wanting 15 mLs of microfat, you're going to harvest somewhere in the 45 ml range. And if you want to take more, that's okay too. I've never had a patient be upset that I took more fat. John, do you have something to that effect?
No, I think I agree with the numbers that you're saying. I'm also an over harvester because I'm also an over injector. And so, I'm always treating the patient in a comprehensive manner. So if we're treating osteoarthritis of the knee, I'm putting 9 into the knee joint. If they have degeneration of their meniscus, I'm putting 2 to 3 in the meniscus. I'm treating MCL or LCL if we're seeing thickening around those areas there. So it's just like a real comprehensive approach. You saw how I did the rotator cuff. We're doing rotator cuff, supraspinatus, infraspinatus, biceps, superior labrum, posterior labrum. So I'm always harvesting a lot more so I can really spread it around.
Yep. You and I practice very similarly. And so if I'm doing a simple intra-articular injection for, say, a knee joint, I'm going to go be approximately 8 to 10 mL. Same with the shoulder. There's some more low volume joints like the hip and the ankle, the elbow that won't tolerate that volume. I'm going to go for, 4 to 5 for those joints. All right, let's see here. There's, let's see here, just like PRP, do you have to hold NSAIDs for MFAT? While this is a procedure that can have some risk of bleeding and bruising, so yes, I do hold all anticoagulants, just like it would be for a procedure prior to, including NSAIDs. And then I'm still quite
Go ahead. Sorry, I just have that on in the background.
yeah, no worries. I'm still quite conservative, and I do hold anti-inflammatories for 4 weeks after my injection-based therapies of MFAT, bone marrow concentrate, PRP, PC, any of those things. I'm still, I think maybe that's going to be changing, but for right now, I'm still quite conservative.
Yeah, I do 2 weeks pre and 2 weeks post.
Fair enough. All right. Let's see here. Let's go through a couple more. And then do you centrifugate the fat aspiration? Yeah, so the centrifugation is part of that aggressive processing for the Joint Tech Labs, MiniTC processing. Absolutely. And then I think, let's see here. If a patient comes in to me stating they had MFAT from another clinic and it was not effective, what should be my approach? John, you want to answer this and then we'll wrap it up?
Yeah. So, first and foremost, I'm asking them what type of MFAT did they get, right? So there are some people that harvest and make their own MFAT without using the F510K cleared kit. So I want to make sure they use the 510K cleared kit. 2 is I'd want to know how they injected it. Did they do it under ultrasound guidance? Did they know the volume of that they were treated with? To get some more, information on kind of what they use. 3 is really what was the body part, right? So MFAT works great for, knees. It works great for shoulders. Guess what? Our orthobiologics don't work great for bone-on-bone hip. A lot of times those patients do better and they're better served with surgery. So kind of, having those type of conversations with them and, getting that information really helps you to kind of make sure that you're choosing the right patient if you do want to kind of repeat it.
Absolutely. Absolutely. Those are all the questions I ask as well. And they're like, ultrasound. I'm like, oh shoot, we don't even know where it went. and like Nathan said, it depends on exactly what type of harvesting, what type of tumescence, what type of harvester, what were you using? Because they were did you use a body jet? And it's quite variable, and a quite low dose. So oh my gosh. Well, we have gone over. Thank you so much, everybody. Thank you, Nathan. Thank you, John. That was amazing and so helpful. And great questions. If we missed your question, please, we'll get to you offline. Thank you so much. There is an advanced technologies laboratory that we do every month. The upcoming events, if you're wanting to go to Clearwater, Florida, come on down. We're going to be doing that December 8th. And we'll be talking about lipoaspirate training on cadaver, bone marrow harvest training, how to do proper dosing and processing of PRP, protein concentrate, how to actually process the MFAT and the BMC. So this is a super fun half-day lab in Clearwater, Florida. Can it get better? And these are the upcoming dates. So if you're interested, please come on down, scan the QR code, and hopefully we'll see you there.
Yes, and best of all, there is no charge for this seminar. We just ask that you give us an RSVP within a week's notice of your desired attendance date. Also, that's very exciting. That is coming up is one of our advanced technologies labs in January. If you can't make it down to Florida, we're doing this one out in Las Vegas on Sunday, January 12th. This is the day following OrthoSono, the most practical regenerative medicine and ultrasound training course put on by Dr. Dawn Buford. So if you were thinking of going to that, now you have more of a reason to come. So scan this QR code to register for the Sunday hands-on cadaver lab. Again, no registration fee. You just RSVP. And then finally, if you would like to order product, here are some instructions and emails in order to get in contact with us. And with that being said, thank you so much to our panelists. We are so incredibly grateful to have such experienced speakers sharing their knowledge and insights on this topic. Dr. Ferrell, Dr. DeMers, Dr. Katz. Another thank you to everyone who was able to be present tonight and spend a little bit of your evening with us. And I hope everyone has a wonderful evening. Thank you again.
Thanks for having us.
Thank you so much. Have a great evening.